Hello, HDFS students, and welcome to our lecture on hospice and palliative care. In this, we'll be focusing on adults. Okay, self-care is important in this class, and so I want you to be thinking about how you're doing and what you need to increase. This could include things like, being with animals or kids, which can be really life-affirming. It can be talking and debriefing with friends or family members. It can be giving yourself a little treat to kind of mark the end of class and switching to something else. It can be being outside in nature. It might be focusing on the things that you do have control over when death makes you feel out of control. So here's those are just some of the things I've heard from students recently. Okay, so these required videos are linked up on the Canvas module overview page, and so I encourage you, they're short, I encourage you to just take a look so that you have an orientation to hospice and palliative care in particular. We'll start with palliative care and then we'll get more into hospice, but these two are overlapping and can be challenging to figure out how they're similar and different. Okay, so as you learned in the video, palliative care is a medical specialty like oncology or neurology or dermatology, right? And so thinking of my mother-in-law who died of pancreatic cancer, she had a surgical oncologist who did the biopsy and diagnosed the pancreatic cancer and determined if other surgeries were viable. Then she had a medical oncologist who was focused on the chemotherapy. Now, both those doctors could prescribe pain medications, but it was hard. It wasn't really their areas of expertise, and her pain was really difficult to manage. And so we sought out a palliative care. They didn't bring it up. We sought it out, a palliative care doctor, also in the same medical system, who would really take over the management of the pain and be an expert on pain medication and that more holistic care. So the first time that she met with the palliative care doctor, there was also a social worker present, and they were asking her questions about what mattered to her in life, what were her priorities at the end of her life that she wanted to be able to keep doing, like going for a walk or maybe driving as long as possible, which means you can't be on super heavy pain medications, or you have to be thoughtful about the timing of them, right, if you're hoping to still do some driving. So palliative care is, again, that holistic care designed to relieve pain and suffering. And palliative care does not have to be focused on death. So it can be for chronic, as you heard, chronic conditions that aren't currently life-threatening, but palliative care doctors can support at the end of life as well. So in the case of our palliative care doctor, they're the ones who would have been prescribing the medical aid in dying drugs that Audrey could have taken as an overdose, what's formerly called physician-assisted dying or suicide. Okay, I think you've learned this in the Coping with Dying PowerPoint when we talked about the physical tasks of dying. But obviously pain is stressful. It tends to dominate our experiences. You can just think about the last time you were in pain. It was hard to focus on other things. And so once we control that, it allows people to focus on, other life goals and tasks, daily activities. And when we don't, it can make us feel really fearful. Okay, so just to help clarify, any non-curative form of care, so if we're not focusing on treating the disease or fixing the disease, right, curing the disease, then that's considered palliative care. So it could be managing pain, it could be managing symptoms like itchiness, rashes, dry mouth, bloating, swelling, right? All the things that we're doing that aren't specifically trying to target the disease, but managing the discomfort around the disease. You can have palliative care exist with curative care. So you could be getting, as for example, Audrey was getting palliative care, pain and symptom management while you're getting, for example, chemotherapy. Hospice is a specific form of palliative care that's different. It's a different designation for insurance and Medicare. And so if you are on hospice specifically, then you cannot have curative care if you're an adult. And we'll be talking more about that. So in case this visual helps you, you can see that you could have curative care only, right? You could be just having a surgery to try to treat the disease. You could be getting palliative care only, meaning you're not pursuing cure anymore, you're just staying comfortable. You could be having both at the same time. But if you want to have hospice, you can't be having curative care. So hospice is kind of a subset of the bigger umbrella of palliative care. Okay, so you can test yourself here, and you can expect on the exam there'll be some questions making sure you understand what's similar about hospice and palliative care and what's different. So, can an adult receive curative chemotherapy and palliative care at the same time? The answer to that is yes. Can an adult receive curative chemotherapy and hospice at the same time? The answer to that is no. Is hospice a form of palliative care? The answer is yes. Does a patient need to have a terminal illness to receive palliative care? The answer to that is no. You could have a chronic condition. You don't have to have a terminal one that you're going to necessarily die from. Does a patient need to have a terminal illness to receive hospice? And that answer is yes. We'll get more into the specifics, but generally a terminal illness with 6 months or less to live. Okay, so palliative care sounds wonderful. Why don't people choose it? You know, as you heard in the video, it's a relatively new subspecialty, so older physicians didn't even rotate through that in medical school. They didn't necessarily learn about it. It's rapidly becoming a part of, you know, more hospitals. Not all hospitals have them, especially in more rural areas. So part of it is that it's new. And so people have kind of confusion about it. They can confuse it with hospice because sometimes palliative care does support at the end of life as well. So they can think that you have to choose curative care or palliative care. They can worry that if the patient is too comfortable or if they're too comfortable that they're going to lose their edge and give up fighting. I don't think there's research to support that so much. Because we think about palliative care associated with dying, just bringing it up is like the idea of bringing up dying, and that's hard for us to do. And we have this valid fear of becoming addicted to pain medications, which I think when I started teaching this class, 17 years ago, we weren't as aware of, but now we are more aware. Now, obviously, if someone's dying, then we are a little less concerned about them being addicted. We just want to keep them comfortable. But if they might live quite a while, then we might, or they might recover, then we are more worried about having them be addicted to these powerful painkillers. Some barriers for doctors. As I mentioned, again, they may not have had training in this area, and they may not have had, they may not be thinking a lot about pain. It's not their specialty. Their specialty is maybe surgery, or it's chemotherapy, or it's other forms of treatment, radiation. They might just be, again, focusing on curative care, and here's what's next. If this chemo doesn't work, then we're doing this one, or if that radiation, then we'll try this. Here's our next steps. Everyone can get very pigeonholed in their specialties. They can think that comfort care seems like you're giving up, and they don't want to give up. They don't want to give a perception that they're giving up on patients, or they don't, want to give up. Again, it can seem like it's tied to dying, and that's hard to bring up, and also fear of addiction. For insurance companies, what can be really tough is that perhaps the most ideal medication for your symptom, your pain, your nausea, is not affordable, is not covered well by your insurance, and so then you're choosing like something that's not so effective, or deal with the difficult symptom, or pay out of pocket. So that's probably the primary challenge. And then secondly, we don't have insurance companies covering in-home care. We're gonna see that you might have a nurse or a CNA coming by to stop and check in on you with palliative care or with hospice care, but you're not having someone who's there, for many hours a day. And a lot of times that's what people need in order to stay out of the hospital. Okay, so this question asks which of these statements is false about palliative care. So 3 are true. And so let's go through them. Its goal is to help manage pain. That's true. To receive palliative care, one must not receive curative care. That's the one that's false, right? Because you can have curative care with palliative care. Hospice is a palliative care. type of palliative care, true, and insurance might be a barrier, true. Okay, so here's a couple of great videos talking about introducing us to hospice and really talking about this issue that hospice is, people enter into hospice too late, and how can you begin to have conversations about exploring hospice earlier, and we'll talk more about that. Okay, so hospice is in the final stages of a terminal illness. We'll get more into that specifically, but it's 6 months or less. Again, you have to give up curative care. So for example, with Audrey, my mother-in-law who had pancreatic cancer, she could not go on hospice until she had stopped chemotherapy and she had decided she wasn't going to pursue any more additional forms of chemotherapy. I have heard that occasionally chemotherapy can be perceived as comfort care, like managing the size of the tumor rather than trying to cure it. But our hospice did not perceive it that way. They perceived it as curative care that she couldn't have if she wanted to be on hospice. Hospice is really trying to prepare individuals and their families for what to expect at the end of life, right? To talk about the things that tend to be unspeakable. Like palliative care, again, that kind of comprehensive, holistic, thinking about the family, thinking about emotions, spirituality, addressing all of those areas of the tasks of dying model. Hospice will often say high quality of death. We're focusing on quality of life and quality of death. Another thing they often say is we do not prolong life nor hasten death. We're just kind of letting the natural processes unfold. And, as we're going to learn, hospice is cost effective. You can get a number of services, and it's at no cost, a lot of services actually, and it's at no cost to you if it's covered by Medicare, Medicaid, or your insurance. I think there might be rare instances where people might have to private pay, or if they're going to a nonprofit hospice, that the hospice will cover that care. So you heard on the videos just that there's some challenges, and people get into hospice really way too late, when in fact they could have benefited from being on it for months if possible. So people are referred late. They don't ask about it. Their physicians don't bring it up, for reasons that we've talked about, that it's kind of taboo to bring up the dying process. And so, as you learned in one of the videos, I think, and are reading in your textbook, suggesting an informational interview rather than like it's time to go on hospice, saying, for example, to family members or friends, it's really hard to choose something when you don't know exactly what it is you're choosing. Would it be okay with you if we had hospice just come out for an informational interview so we understand what it is going to involve and what the process is like, so that we're not having to, decide that during a really stressful time, and it'll give us a better sense of when is the right time. And, I think truthfully, a lot of times just having that informational interview, people will go on hospice much more quickly. So for example, I did that with my mother-in-law. As soon as she stopped chemotherapy, I had hospice out within a couple of days. I said, let's just do an informational interview. My sister-in-law at that point was still thinking she had months to live. I didn't think she did. So it was a soft way of saying, let's have an informational interview. And Audrey signed up that day, in part because it was free and she got all of these amazing services. They were going to bring her a wheelchair and a bedside commode and something to get in and out of the shower, and they're going to deliver her prescriptions. And she was always very frugal, and so the fact that we weren't going to have to buy a wheelchair or a walker, and that they were just going to drop that off same day, that was pretty mind-blowing, as well as the additional kind of nursing and medical services that we'll talk about. Okay, so for physicians, physicians obviously have a hard time maybe giving up on cure oriented. Like if you're a medical oncologist, you're just going next chemo, and not always stopping to think like, what's the quality of life here, and what's really worth it. Some I think are better, some doctors are better than others at bringing up quality of life conversations. And then physicians will often tell you, and I think it's accurate, they have a really hard time predicting how much time you have left. And so when they're asked to say, do you have 6 months or left, they're like, 6 months or less left. They're not sure, because our disease can go so up and down, or you can deteriorate really quickly. So just a little bit more on how hospice came about. So in 1982, 83, our federal government passed a law, the National Hospice Reimbursement Act, which created a Medicare hospice benefit. So Medicare for older adults, right? It allowed that you could go on, you could kind of agree to go on the hospice benefit and get all these services at a very low cost. Now insurance companies and Medicaid also cover hospice. You have to meet 3 conditions. So one, both the patient's physician and the medical director of the hospice, which is an MD, is also a medical doctor. The medical director is a medical doctor. They both have to agree that you have a life expectancy of 6 months or less. However, people get hung up on that. Well, what if you live longer? Do you get kicked out? No, there would just be a recertification process where your doctor and the medical director for the hospice would again look at your records and say, okay, you've made it 6 months. Do we think that you're still likely to die within the next 6 months? And if you are, then they would recertify you for hospice. If you weren't, then you would come off hospice. You also can at any time revoke hospice. So you could be on it and then find out that there's this new medical treatment that you want to do that's curative, and you could go off hospice so that you could try this treatment. The patient obviously has to agree and sign the paperwork to receive care instead of the basic services that the other services that they've been on, whether that's skilled nursing or palliative care. They have to say, I want to be on the hospice benefit. And then the hospice has to be certified by Medicare. So for a long time, I think most hospices were nonprofits, but now we have some for-profits as well, but all are certified by Medicare. And Medicare has certain rules about who they will pay and who they won't, and so that often dictates like who can work at hospices and what are the things that they can do. Okay, so here's some myths about hospice. So sometimes people think about hospices as a place, and sometimes they are. Some hospices are residential, meaning they have beds that patients can stay in, and some are not. So, for example, our nonprofit Pathways Hospice in Fort Collins for many, many years was not residential, but in the last couple of years did build a hospice house where with a limited number of beds, where some patients who aren't able to be cared for at home and are trying to stay out of the hospital or aren't a part of skilled nursing facilities or assisted living facilities can come. People think that signing up for hospice means you're going to die right away, and I think the perception is that because people sign up at the end. So we often hear like, oh, he's on hospice and then he dies 3 days later. But if you actually get familiar with a hospice or work or volunteer at a hospice, you'll learn that many people are on hospice for months and maybe are recertified for multiple 6 months periods. People can continue to work. They can, if they want, they can continue to live their lives. They don't have to give everything up and go lie down in bed if that's not where they're at. Hospice isn't expensive. It's actually, I think, free. So you don't pay for anything. It's covered by either Medicare, Medicaid, or your insurance, or nonprofits. There may be instances where people pay that I'm not aware of, but generally it's super cost effective. This idea that hospice just puts everybody on morphine and addicts people and hastens death. Obviously, morphine is an addictive substance. We weigh the pros and cons of that at the end of life. Generally, the hospice philosophy is not to hasten death, but as you heard on one of those earlier videos, it could be that once you're on higher doses of morphine, it does kind of suppress breathing, slow down breathing, and it might, for example, slightly hasten death. Another perception is that maybe only older people with cancer qualify, right? When in fact, kids can be on hospice, young people can be on hospice, and for many different conditions, you can receive hospice care. So when physicians and medical directors are deciding if someone has 6 months or less to live, there are some conditions that kind of automatically qualify you that say, yep, you've got 6 months or less, and that's stage 4 cancers, that's advanced organ failure like heart, liver, kidney, in-stage neurological diseases like ALS, and advanced HIV. Or if you don't have one of those kind of automatically qualifying diseases, then you have to document that this person has had a loss of 3 or more basic activities of daily living. And so there's considered 6 activities of daily living: bathing, dressing, toileting, transferring or ambulating, so getting in and out of a chair, walking, continence, so so being able to maintain your bladder and your bowels, and eating. So 3 or more of those. Rapid weight loss, that can vary. Is it 5% in 3 months? Is it 10% in 4 to 6 months? And then at least one of the following: 3 or more hospitalizations or visits to an emergency department, and this is kind of recently, right? Decrease in physical activity and decrease in cognitive activity. Those of you who are working in healthcare professions, you'll probably find checklists that are even more specific than this. So I just want to acknowledge that, even though hospice, we talk about it as a really positive thing, sometimes it's not always that positive. Hospice is only as good as its management and the people that work there. And also, if hospice is being asked to come in really fast sometime at the end, it can be hard for them to do everything well in a short amount of time. So sometimes people have, what I hear from students is mostly positive, but occasionally some negative or mixed experiences. Okay, so hospice is kind of famous for saying we're going to come wherever you are. So most of it is delivered in patients' own homes or family members' homes. For example, hospice can come to hospitals. And then other facilities like nursing homes or assisted living facilities, rehab facilities, or standalone hospice residential facilities or hospice houses, or anywhere hospice calls home. So if you're living in your car, they'll come to your car. Hospice has pretty amazing teams. So each patient is always going to have a medical director, which is a medical doctor assigned to their case. And there's usually just a couple of medical doctors, obviously, surveying all the patients or overseeing all the patients. And then each person is also going to have an RN or a nurse assigned who's always going to be coming out at least once a week if things are going well, and obviously more often if not. CNAs, certified nursing assistants, which many of you have experience with, might be coming 2 or 3 times a week to provide kind of bathing or hygiene help and care. Social workers, they're always going to be present at the hospice admissions process to kind of help facilitate all the paperwork and decision making. And then it's kind of as needed or as wanted following that. They can be very involved in kind of providing counseling for the family or for the patient, or they can be less involved depending upon what the patient prefers. Similarly, chaplains, which are non-denominational, kind of spiritual, but certified or trained spiritual leaders. Patients might want them a lot, patients might not want them at all, but they are a standard part of the hospice team unless their services are refused. Hospice does provide 24/7 phone support, which is really great for staying out of the hospital because you can call them whenever you're in distress and they're going to come in the middle of the night quickly, generally. They do provide, I skipped over, pharmacy and medical equipment is huge. So I can speak from experience with Audrey. When my mother-in-law Audrey was dying, we spent a lot of time trying to secure her various pain meds, especially as they were changing. So one pharmacy wouldn't have it in stock, and so we'd have to get it from another pharmacy, and we're calling to see if it's ready, and it's taking a few more hours. And it was a lot of time spent on the phone with pharmacies and figuring out who had it and how to get it. And hospice just gets it and delivers it to your door. So that in and of itself is practically just worth going on hospice, I felt like. And then similarly, they provide lots of medical equipment. So when Audrey was deteriorating on chemo, we were figuring out, okay, I think we're going to need a wheelchair. I think we're going to need a walker. Maybe we need a bedside commode. Maybe we need a hospital bed. Hospice just drops all that off at your house on the exact same day that you requested, or like within 24 hours. And so now you're not just on this scramble to try to find it or pay for it. Hospice also really helps with the aftercare body care, so that, knowing what's going to happen after death in terms of, burial or cremation. And then hospice facilitates that. They know at the time of death, they contact the funeral home, all that is kind of done behind the scenes so that family members aren't having to figure that out. And then hospice has some really nice additional services. It depends upon hospice, but they can provide music therapy, which is, we often have music therapists in this class. And a lot of times they're showing up to just find out what music would be enjoyable for the patient. And that could be songs from growing up. It could be more like, pop music, or it could be religious music. Occasionally it can be more involved in terms of kind of writing songs. There are music therapists who specialize in kind of music at the time of death. I think that's a little less common. Art therapists can be supporting both before and after death for family members. Massage therapy, pet therapy, and then volunteers. And so I'll just encourage you to consider being a volunteer for hospice. I think it's a great experience. Usually you get good training too. And so you can be a volunteer in different ways. You could just volunteer in the hospice building, right? Just doing kind of random tasks. You could volunteer in patients' homes. You could either come and sit, for example, by the bedside so that caregivers can go run errands. You could also be the person running errands and getting the groceries and bringing things back. So just a great opportunity. Okay, I just want to create space for what else you know, and how that might or might not fit with how I've been talking about things. And I encourage you to share that with me if you'd like to. Okay, where does most hospice care take place? Testing yourself on that. And this is in a patient or family member's home or friend's home, so in a home. So one of the huge benefits of hospice is that you are more likely to die at home rather than in a hospital. And most people would prefer not to die in a hospital. Occasionally, I think people do, but most people would like to die at home. That's their vision of a good death. Hospice makes that possible because what's going to happen near the end of life is there's going to be odd things. There's going to be crises. So for example, with Audrey, it was like she was experiencing chest pain. You think chest pain, you think call 911, right? But when hospice does its admission, it makes it very clear that you don't call 911 because then you're going to go to the hospital and you're going to die in the hospital, more likely. So there you put things up on your fridge that says hospice, don't call 911. And that way, if, for example, an EMT does get called to the home, they know to get hospice involved and not transport you to the hospital. Because what you can see from this research study is when people are in their last month of life and older, if they visit an emergency department, then they are highly likely to be admitted, and then they're likely to stay and die in the hospital. Those who are on hospice at least 1 month before death don't go to the hospital. And I thought this was really interesting. My husband asked some of these questions like, what if my mom falls and breaks her hip? Doesn't she have to go to the hospital and get it treated? And what the hospice nurse said is, if it's a compound fracture and bone is sticking out her skin, then yes, and we can't, we have to maybe treat that. But if it's just a broken rib or a broken hip, she's not going to live and doesn't need to properly heal or recover from that. We can just manage that with additional pain medications and keep her comfortable at home. And I thought that was really enlightening. So in her book, The Art of Dying Well, Katie Butler has some tips for dying at home or in a facility. And so dying at home might be getting a hospital bed, even if you have to put it in your living room, just so it's easier to get in and out of, and you can incline and decline, having a wheelchair, having a bedside commode, having just things like diapers. They now have charcoal pads that can be on the bed for pets or humans that can absorb odors. Maybe towels that are dark colored, like black, so that if there is blood or, feces, right, that it's less noticeable or shocking, I guess I should say. You can also use other charcoal briquettes under the bed to just help absorb odors. Having just easy food available for family members or friends who might be kind of coming by, right? So that there's snacks in the kitchen. Having all the paperwork in one clear place. Usually people say putting it on the fridge. Hospice will often bring you something to keep everything on the fridge. Preparing for a nursing home death. I think this sometimes might seem unreal, might not be realistic for facilities, but facilities could create special rooms for the end of life or designate rooms that are for the end of life that have good lighting, that are maybe out of the kind of noisy parts, that maybe have the capacity to play music or to bring in extra seating, maybe putting a sign outside the door indicating that this person is, end of life, so that people don't just walk in like all upbeat, how are you doing today? Somebody's new, covering a shift, right? Just kind of being more sensitive. And then really thinking about what, if this person is truly dying, do we need to be monitoring them every few hours, or do we need to have all these tubes connected? What can we do to just keep them more comfortable here at the end of life? Okay. I hope you'll just watch the 4.5 minutes of this video clip, especially if you are ever someone who is going to need to prepare people for what to expect at the end of life in the dying process. If you expect to do that personally or professionally, I think this is the best example I've seen of someone it's a doctor, talking a family through what it's going to look like at the very end of life and how not to panic. And so, yeah, I would encourage you to take a look at that and put some things in your toolbox. Here's some of the things you may have heard on the film in addition to other signs. So I've got 2 slides here. The first one is during the last days or hours, and then the next slide is actually at the time of death. So the body systems do tend to slow down. So heart rate, breathing can all decrease. Breathing can also be irregular, so people can take shallow breaths and then they can stop breathing and then they can have deep breaths. They can appear to have difficulty breathing, or even kind of noisy, congested breathing, and so that's often called like as it gets more pronounced, it's called like a death rattle, and that's just, as I understand it, saliva kind of collecting in the back of the throat. The person's body is having a harder time clearing that, and so it can sound more congested. It can be distressing to listen to, but generally, people will tell you that they don't think the patients are experiencing the distress that we are at listening to it. People might be agitated or anxious, kind of pulling at bed sheets, jerking, and so sometimes that is what warrants an increased sedation. They might be confused about who you are, what time it is, what year it is. Their circulation is decreasing, so as the body begins to shut down, it concentrates its focus on the core, on keeping the organs functioning, on blood flow to the organs. And so skin color can get more bluish or mottled. Extremities can get cooler often. So I noticed the day before Audrey died, her hands were really cold. Although people also talk about kind of sweating or hot. I have heard that as well. People have decreased appetite, and a lot of times we want to continue to feed or hydrate, to keep them hydrated, keep them fed. And while that's something that we would want to do when someone isn't dying, by the time their body is starting to shut down, it actually can't process all that fluid. It's just going to lead to a lot of edema in their body. And it certainly can't process all that food. So people start to decrease their urine and stool output, and that's really normal. Usually people are sleeping more, they seem detached, they might stop being able to communicate or talk if they were able to do that, but they might also have bursts of lucidity. And I didn't mention seeing other people, but hospice nurses will tell you that people often talk about seeing someone. It might be someone they know, but oftentimes they just might seem to think that there's just other people in the room that even they don't know. Okay, so then that congested breathing and that death rattle can get more pronounced at the time of death. Not for everybody, but just that relaxing of the throat muscles and increased congestion. Breathing obviously will eventually stop. There might be kind of some last heaving breaths, which can be distressing to watch, but are pretty normal. The heart may continue to beat after breathing stops. So it's really nice to have a stethoscope or someone who's there with a stethoscope who can tell you when exactly the heart has stopped beating. Eyes do remain partially open, not usually in a staring way, kind of in a half asleep way, because it takes muscles to close our eyes. The mouth may, because it takes muscles to keep our mouths closed, the mouth may fall open. Generally, the bladder and the bowel will release, so you want to have kind of absorbent pads underneath the person to kind of account for that. And I think we have sometimes a fear at the time of death and a desire to just call a funeral home or a hospital or an ambulance like right away, but in fact, I would encourage you, if you're okay, to slow that down. It can be even though we have a fear of dead bodies, just kind of breathing through that and being with someone for some period of hours after their death can actually can give a sense of closure. It can be a pretty profound time. So, for example, when my mother-in-law died, we were still driving home from Montana. We were about 10 hours away. And so my sister-in-law, we asked if she could stay, if if the funeral home could wait to pick her up until after we had had a chance to see her. And so my sister-in-law ended up spending the day, with her mom's body, kind of coming in and out of the room, talking to her about her beliefs, hopes, for her in afterlife. And I think it was both difficult, but also really important. And then when we came, we brought the kids in, including my younger niece, who was 10, and we had all, in the interim, written letters to her of things that we wanted to say, because we were caught off guard. Ideally, we would have written these before she died, but we didn't. And so kids had drawn pictures or written letters, and we all kind of took turns standing in the room around her body, kind of reading her, our last messages. Okay, it was a tough way to end the PowerPoint talking about signs of death. So take some deep breaths, let it go, look outside, see the beautiful world around you, and transition to the rest of your day.